Hello everyone, I am Dr. GCKhilnani, Chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine, and formerly I was Professor and Head of the Pulmonary Critical Care and Sleep Medicine at the All India Institute of Medical Sciences. Today we are going to discuss a very special aspect of management of obstructive airway disease, that is single inhaler triple therapy called SITT, and its use in asthma and COPD. The question is it the future of aerosol therapy? So, first I'll discuss about SITT for asthma. And we know that we have GINA guidelines of 2024 and also the GOLD guidelines of 2024. I'll also be discussing both the diseases in the light of these latest guidelines. If you talk about global burden of asthma, 9% of children, 11% of adolescents, and 6.6% of adults are having asthma. That means that they have a tendency for asthma. And if we talk about global burden, almost 2.6 million people in the world have asthma. And if you talk about India, 35 million people are suffering from asthma. Unfortunately, only fewer than 30% of the people with current Bs, the diagnosis of asthma is established by a doctor. Furthermore, the daily use of inhaled corticosteroid is less than 10%. And because of the poor control, more than 25% of the patients are hospitalized at least once in a year, probably due to inadequate treatment. It's not that asthma does not kill. All over the world, annually, as many as 250,000 people lose their lives because of treatable disease of asthma. And another unfortunate thing is that 80% of our deaths are occurring in the developing countries, and 2 out of these 3 deaths are preventable. So, what do you want to achieve in asthma? We want to achieve good control so that patient lives a normal life, maintain normal activity level, maintain pulmonary functions close to normal levels. More importantly, we want to prevent asthma exacerbations and prevent asthma mortality. At the same time, we want to avoid adverse effects of asthma medications. So, if we talk about asthma treatment, what are the treatable traits? Of course, we know there are exacerbations of asthma, which is very important. There is airflow obstruction or airflow limitation, which is the hallmark of asthma. There is neuronal plasticity. There is eosinophilic inflammation. There is small airway disease. There is mucus hypersecretions. And there is neutrophilic airway inflammation. Now let's look at it how the medication works. When you give inhaled corticosteroids, it prevents exacerbation. It controls eosinophilic inflammation, and it also affects positively small airway disease. And when you combine it with long-acting beta-2 agonist, there is less of exacerbations. The airflow limitation is better controlled. Eosinophil inflammation is controlled. Mucus hypersecretion is controlled. And when you add LAMA, that is long-acting anti-muscarinic agent, then all these traits from exacerbation to airflow limitation to neuronal plasticity to eosinophilic inflammation to small airway disease to mucus hypersecretion to neutrophilic inflammation. Now the question is, should we add these three components of aerosol therapy to all our patients, or can they be given in one device? So lately there has been availability of all three medications, class of medication in one device. It is some are imported and some are now available in India also. They are available both in the DPI form, also now they are available in the MDI form. The question is, what is the use of this triple therapy, if I may call, in management of asthma? The latest guidelines of GINA 2024 said that LAMA is used only in step 5. Up to step 4, inhale corticosteroids and in short acting, the beta 2 agonist, that is a combination of ICS with formoterol, is the main treatment up to step 4. Only at step 5, there is a role of LAMA, long acting antimuscarinic agent, or you give high dose ICS with formoterol, or you give biologic in the form of anti-IgE, anti-IL-5, or anti-IL-5R, or anti-IL-4RA, that is dupilumab, or anti-TSL. Now in India, the cost is an issue, expertise is an issue, and it is also said that increasing the dose of inhaled corticosteroid does not have much benefit. So therefore, there is a distinct role of adding a LAMA into the step 5 of therapy, both in the track 1 and track 2, which is alternative in GINA guidelines. So summarizing is that in step 1 and 2 in GINA guideline, in step 3 and 4, ICS LAMA is the main treatment. And step 5, there is role of ICS, high dose ICS or LAMA or biologicals. So can we add all three in one device and can be given once a day or twice a day? When we give the separate inhaler, separate devices, the compliance goes down. So the combination which are available like beclomethasone, formoterol, glycopyrronium, fluticasone, elentrol, umeclidinium, momentazone, indacaterol, and glycopyrronium. What are the advantages? Is there an evidence? There's a meta-analysis which showed that there is 17% reduction in the risk of severe exacerbation with addition of LAMA to the medium or high dose inhaled corticosteroid and LAMA combination. So there is distinct advantage of adding LAMA in step 5 of GINA therapy. So can we combine them both? And what is the availability? So several approved combinations are available. Some are given once a day, like this Trilogy Lipta, and some are given twice a day. Some are used for COPD, some can also be used for asthma. So this was a systemic review of triple therapy, SITT therapy for asthma. And it was conducted. In this review, there was a systemic review to identify all phase 3 clinical trials investigating triple therapy in asthma. There was 5 phase 3 RCTs, which includes the trimaran, trigger, iridium, argon, and captain. So let's look at these trials. This trimaran and trigger study compared the efficacy and safety of triple therapy, that is beclomethasone dipropionate, formoterol fumarate, and glycopyrronium bromide, with medium dose uh, beclomethasone and formoterol and high dose. So let's look at what were the results. In the trimaran, when triple therapy was compared with the LAMA-LABA combination, sorry, ICS-LABA combination, there was a FEV1, the trough FEV1 was significantly high with triple drugs combination. And also the severe exacerbations were much less, significantly less with triple therapy as compared to dual therapy. The There was not much difference between high dose and medium dose corticosteroids. Similarly, in trigger trial also, the FEV1 was significantly more in with triple therapy as compared to dual therapy. As far as the exacerbation was concerned, the those were also less with the triple therapy as compared to the ICS LABA combination, but the difference was much less in the two. So the conclusion was there was a higher FEV1 at 26 weeks, fewer exacerbation, particularly the severe ones at 12 months, no clinically relevant impact on asthma control, but fewer adverse events, mostly mild to moderate exacerbation. Another study, that is Iridium study, compared the effect of once daily SITT with the medium and high dose mometasone furoate, indacaterol, and glycopyrronium bromide, either once daily ICS LABA or twice daily high dose fluticasone salmeterol was given to this patient. Now, result was when the FEV1 was much higher when high dose triple therapy was given. And there was not much difference between medium dose and high dose. But the fact was that at 26 weeks, both medium and high dose SITT were associated with greater improvement in trough FEV1. Asthma control score was not different in SITT versus equivalent ICS LABA combination, and SITT did not significantly reduce annualized rate of moderate or severe exacerbation. Adverse events were also similar across groups. So, what is the conclusion of the triple therapy? The conclusion is that SITT has the potential to improve treatment adherence, reducing the number of inhaler devices for maintenance treatment with less instructions and no different dosing regimen. So where do we position SITT in asthma management? Consider high dose ICS dose in SITT, that is one, before using oral corticosteroids or biologic, particularly if there is a persistent airflow limitation and or history of severe exacerbation, or certainly in patients not eligible for biologic treatment. So there is a place for triple therapy, that is single inhaler uh, triple therapy in patients with asthma in step 5 of GINA, where once or twice daily inhalation therapy would suffice, and there is some evidence that the FEV1 is significantly improved and lesser number of exacerbation with less of adverse effects. Coming to the another obstructive airway disease, that is chronic obstructive pulmonary disease, where is the place of single inhaler triple therapy? Now, unlike asthma, the goals of managing severe COPD are different. And what are these? One is that we want to achieve good quality life, that is good exercise capacity. Second is that we want to prevent exacerbations. We want to prevent pneumonia, which is common with COPD. We want to reduce mortality, as we know that COPD is has become a second leading cause of death in India and third leading cause of death all over the world. Reduce the cost of therapy, minimize number of inhalations per day. The question is how to achieve these goals, the place of triple therapy in COPD, and we'll examine that part. So, the pharmacotherapy of long-term management of COPD includes LABA, that is bronchodilators, and ultra-LABA, starting from formoterol to salmeterol to endacaterol to vilanterol to holodestrol. Long-acting antimuscarinic agent, that is LAMA, from glycopyrronium to tiotropium to echinidinium, and inhaled steroids from fluticasone to mometasone. So, when to use triple therapy? That is the question. Can there be, can three be combined in one device? And what is the evidence of benefit? So the latest GOLD guidelines have altered. Group C and D has been combined into group E. And if I could summarize at the outset, that we are not today discussing group A and B, we are discussing the severe COPD. So if there are more than two moderate exacerbations or more than one leading to hospitalization with COPD, that falls into group E. If there is an increased number of eosinophils in the blood to the extent of 300, that qualifies for triple therapy, that is LAMA, LAMA, and ICS. So let's look at the evidence as to when should we use triple therapy. And this is a landmark study called Impact Study, which was published in the New England Journal of Medicine in 2018. It was a randomized trial with 2:2:1 design. And there were more than 4,000 patients in the arm, triple therapy arm, with umocridinium, volantrol, and fluticasone furet. It was compared with fluticasone furet and volantrol, that is ICS LABA, and third was LABA LAMA. They were followed up, and total duration of study was 1 year. The population was when the FEV1 was less than 50% with more than one moderate or severe exacerbation in the past 1 year, or 50 FEV1 of 50 to 80% with two moderate exacerbations last 1 year, one severe exacerbation requiring hospitalization. What were the results? The annual exacerbation rate was significantly less in triple therapy as compared to the ICS LAVA and LAMA LAVA. The lowest was in the triple therapy, followed by ICS LAVA, and the worst was LAMA LAVA combination. Also, when another study, when the medium dose and high dose inhaled steroids were compared, that the exacerbations were less in triple therapy, but the medium dose and high dose steroid, there was not much of difference, but definitely as compared to the LABA LAMA and the ICS LABA, the exacerbation rates with triple therapy was much less. Also, there was 24% reduction in exacerbation rate versus LABA LAMA. There was 13% exacerbation rate reduction as compared to ICS LAMA. Now, this study showed that there was significant reduction in severe exacerbation with triple therapy with LABA LAMA. This is a study by Lipson DA in the New England Journal of Medicine, where the severe hospitalizations were significantly less with triple therapy as compared to the ICS LABA and LABA LAMA combination. The difference between ICS LABA and triple therapy was not significant, where the difference between triple therapy and LAMA LABA was statistically significant. So the conclusion of these studies was that triple therapy reduces exacerbation, especially severe ones in patients at high risk of exacerbation. The other outcomes of this impact study was that ICS plus LABA seems to be more effective than LABA-LAMA in reducing exacerbation without any class effect. The dose of inhaled steroids seems to have no impact in reducing exacerbation. Hence, given effect is causing pneumonia, better to stick to the lower dose of steroids. Now, is there an effect of triple therapy on mortality also? That is a question. Now, this particular study has shown when the patients have severe exacerbation requiring hospitalization, this is the duration in terms of years 0, 2, 4, 6, 8, 10. The mortality goes up. If there are 5 exacerbation, 4 exacerbation, 3 exacerbation, 2 exacerbation, larger the number of exacerbation, higher is the mortality. So the focus from FEV1 has changed to the exacerbation as far as the outcome is concerned. So the all-cause mortality in patients who received triple therapy was less than those who received dual therapy. This was the result. So conclusion was that triple therapy have impact on reduced exacerbation reduction, lung function, and quality of life. And there is some evidence to show that mortality is reduced in patients on triple therapy. The last part is, does eosinophil counts indicate benefit of inhaled corticosteroids? So you have to choose your patients. You have to know some parameters as to when you should go for triple therapy. Now, the blood eosinophils and inhaled corticosteroid, the relationship is that when the eosinophils are less, there are more bacterial infection, there is more neutrophilic inflammation, and there is smaller effect of inhaled corticosteroids. On the other hand, if the eosinophils are, there is a cytokine T2 based inflammatory pathway leading to cytokines and chemokines and remodeling with the which have a greater effect of inhaled corticosteroids. So this is a landmark study published in the Lancet Respiratory Diseases. These are the x-axis is the eosinophil, 100 per cubic, 200, 300, 400, 500, 600. So at 500, the effect of triple therapy, that inhaled steroid is the maximum. The annual rate of exacerbation is very well controlled when you give inhaled steroids based treatment to patients who have high eosinophil count. On the other hand, when you give dual therapy with LAMA-LABA combination, that then the exacerbation rate is much more. What is the inference? The inference is that when the eosinophils are more, there is a better effect of inhaled corticosteroids as compared to the patient where the eosinophils are less. What is the implication? That the conclusion is that increased eosinophil count predicts greater exacerbation in patients with COPD. Increased eosinophil count predicts response to inhaled corticosteroid, including triple therapy in patients with COPD. So this is what GOLD 2024 says. The factors to be considered when initiating inhaled corticosteroid treatment. The strongly favored factors are the history of hospitalization for exacerbation of COPD. That is one. If there are more than 2 moderate exacerbation COPD per year, if the blood eosinophils are more than 300 cells per cubic millimeter, or if there is history of or concomitant asthma. It favors use of inhaled corticosteroid if there is a moderate exacerbation of COPD per year, one exacerbation, and blood eosinophils are 100 to 300. However, if there is a repeated pneumonia events are there, if the eosinophils are less than 100, or if there is history of mycobacterial infection, that goes against the use of inhaled corticosteroids. So this is the crux of the whole triple therapy. So if you have a COPD patient, look at the exacerbations. Patients should be started on LABA LAMA. If the blood eosinophils are less than 300, LABA LAMA can be continued. If the eosinophils are more than 300, then LABA LAMA and ICS is the drug of choice. If the eosinophils are more than 100, and if the patient is not responding well, you can consider triple therapy in form of LABA LAMA ICS. Now, if the blood eosinophils are less than 100, then you can consider other therapy like rofimulast if the FE1 is less than 50% and there is a chronic bronchitis. Then consider azithromycin or other preferentially in formal smokers. So therefore, if the eosinophils are less than 100, the inhaled corticosteroid or triple therapy should not be used. Now, when you consider de-escalation of ICS, if pneumonia or other considerable side effects are there, otherwise, the de-escalation of inhaled corticosteroid leads to the exacerbation. So, therefore, the inhaled corticosteroid should be de-escalated only if essential in view of the high chances of pneumonia. If the blood eosinophils are more than 300 cells per cubic millimeter, de-escalation is likely to be associated with exacerbation. So all this should be kept in mind. Now finally, the using multiple inhalational devices has problem. As the number of devices used increases, the treatment complexity increases, adherence to treatment goes down, and chances of medication error are high. So an assessment of this is warranted. So single inhaler triple therapy has a potential to circumvent all this problem in the treatment. So what is the conclusion about COPD and single inhaler triple therapy? SITT reduces exacerbations, especially severe ones in patients at high risk of exacerbation. ICS LAVA seems to be more effective than LAVA LAMA in reducing exacerbation without any class effect. The dose of inhaled steroids seems to have no impact in reducing exacerbations. Hence, given effect in causing pneumonia, better to stick to lower dose of steroids. This is important. There is some evidence to show that mortality is reduced on single inhaler triple therapy. The risk of multiplies with severity of exacerbation, so that should be kept in mind. Withdrawal of steroid in exacerbation prone population increases the rate of subsequent exacerbations. The increased eosinophil count predicts greater exacerbation in patients with COPD. Increased eosinophil predicts response to inhaled corticosteroid include triple therapy in patients with COPD. The gap in differential response widens as we grow from low to high eosinophil counts, comparing LABA-LAMA ICS versus LABA ICS. Finally, so the GOLD 2024 update says, together, these results suggest that a beneficial effect of fixed dose triple inhaler therapy versus fixed dose LABA-LAMA combination on mortality in symptomatic COPD patients with a history of frequent or severe exacerbations. So therefore, triple therapy has a future. Probably a patient can be managed on once or twice daily inhaler. So conclusion is that triple therapy provides clinical benefits. Triple therapy should be used in a personalized manner in selected cases. Ladies and gentlemen, thank you very much for your kind attention. If I would appreciate if you could write back to me on my email or WhatsApp to me on my mobile about your comments and queries, and I'll be most pleased to answer your question. Thank you so much and have a good day.